Okay, Dr. Crawford, we're ready for questions and answers from the experts, from you particularly, since you're the primary expert here. The first one, I'm going to just give a little bit of a definition because it's about grounding sheets. So a lot of people have maybe never heard of a grounding sheet. So grounding sheet is made of specific material that people put on their bed or wherever they want to put this sheet, but it's designed to mimic the natural charge of the earth by connecting a person to the earth's surface via a grounded electrical outlet. So it evidently I haven't seen one in person, but it evidently has something that goes into the electrical outlet. So that the question is that safe for somebody with a pacemaker?
So, if I understand the concept correctly, it simulates the Earth's electromagnetic field, so which we're already in it. So, I would say that a safe answer would be to say that it should not matter just because it's plugged in to the outlet. I would say that that's a new question that I've not encountered in the past. Either it's something that's just very recently came out, or it really isn't an issue at all. So what I would say is that I'm not sure about the benefits of those grounding pads myself, but I would say that as long as they are what they say they are, they should be safe.
Yes. And if you're really worried, you can always check with your device manufacturer, right? Just pick up the phone and call them, or I've done that with Medtronic before, picked up the phone and called them about something. Yeah, I agree with you. It seems like it would be safe, but you can always check if you're concerned. Okay, the next question is pertaining to surgery. So this person is due to have a hand operation, but they were told that their device would be turned off during general anesthesia. And this person found this very terrifying to think that it would be turned off because they say theirs works 40% at the time, and they have it because of the heart slowing down and pausing. So the person refused the operation for the hand, but the hand is still very painful. So they don't know what to do, and they're wondering, are they just worried for nothing?
So what I would say is that I don't like the term turning off in this context. So if it's a pacemaker, what you can do is you can reprogram it to a different mode. It's not really turning it off. It's programming it to a mode that is not going to see this electromagnetic interference. If it's an ICD, you can suspend therapies, meaning suspend shocks for a period of time. And that can certainly be done, and is routinely done.
It's also very common, right? Where somebody has a pacemaker and they have to have surgery and they have to do something specific with the pacemaker.
Correct. I mean, if for pacemakers, the general rule is if surgery is above the umbilicus and somebody is pacemaker dependent, you should either place a magnet on the device in the OR, or you should reprogram the device to essentially what would be an equivalent of a magnet mode. If surgery is below the umbilicus, you really can do whatever you want. Now, if you're really having, was it carpal tunnel surgery or some type of
It
hand
just said
surgery?
hand.
I would say it's so far from the device that I do not see a reason why that would necessarily be a major interaction because it's very far. However, what I would say is I would defer to the expertise of the providers who are doing the care because we're just trying to make statements that are sweeping in nature, and we just kind of broadly paint the brush of, how you should behave with a pacemaker or how different providers will act with it. But the bottom line is that I would assume that the providers who are at that institution know exactly what they're doing. We never turn off pacemakers. We just reprogram to a different mode. Now, defibrillators can be turned off upon patient's request. You can turn off therapies if somebody is, for example, dying of cancer. They don't want to be shocked. And so you can actually, with the programmer head on the device, when the patient requests, you can disable those therapies. But in the setting of an OR, the typical approach is if the device is reprogrammed before the surgery, it is programmed back to its original settings after surgery. And during surgery, you're being monitored with an EKG lead for sure. I mean, people don't get sedated without that. Even if the device is disabled from shocking a patient during an hour or two, the patient is still under the active care of providers who know how to deal with issues.
Yeah, and it's common practice, and they're watching you the whole time you're under surgery. Particularly, the anesthesiologist is constantly monitoring your heart rate and your breathing and making sure that hemodynamically everything's working right. I would think that this is And I don't think the person's worrying for nothing. I think you should always be concerned when you're having surgery and ask a lot of questions. But yeah, common practice. Thank
Agree.
you. Okay, the next one is about exercise. How soon can you restart upper body weightlifting? And are there weightlifting limits to movements you should always avoid? So, really, that's two questions. After you get a pacemaker, how soon can you restart weightlifting? And then after that, once you're healed, are there any movements to always avoid?
I would say that um, it would be reasonable to avoid heavy lifting in the first 2 months after an implantation of a device. Something like bench pressing, or it depends really on the weight. If you wanted to train your biceps with 5 or 10 pounds of weight, I think that would be probably okay. But if we were to create like a general rule, I would say up to 2 months, maybe you should refrain from doing things that are heavy. After the first 2 months, you really ought to be able to do anything after that. Now, does that mean that patients who exercise with weights, like, muscle builder folks, that there's no increased risk from that practice? I would say the answer to that is probably no. There is some issue if the bar comes down and hits the clavicle, with some, like, I could imagine the scenario in which this might be a consideration. But, I have a lot of patients who are very physically active with weights and swimming and other things. I've just never heard of a problem with that,
Yeah,
even though there are some theoretical considerations.
sure.
I think what's important is that the body likes gradual increase in intensity to any exercise or weightlifting. So I think whatever you do, you should start at levels that are, approximate your current activity, and then you gradually increase that, and you let your body get used to the demands that you're putting on it. And so I think as long as you do that, I think it should be fine. You can do virtually anything.
Yeah.
Now, if you were an Olympian that's lifting extremely heavy things, that might not apply. But I would say it all depends on the intensity and the ramp up to that activity.
Yeah, yeah, that makes sense, especially since they're going to be 2 months where they have to limit and then they have to build back.
Correct.
Yeah.
Correct.
All right. Thank you. Okay. The next question is regarding settings. So she's tried working with her cardiologist on settings. She's a lifelong runner and has dizziness and nausea running a 13-minute pace when exiting her car and on the stairs. Prior to the implant, she could run a 9 to 10-minute pace. So now it's longer. When she runs uphill, the heart rate decreases, but she needs more of a pace. It seems like the sync needs time to catch up. Question mark. Are there people that coach distant runners? She was running marathons for 30 years and wants to compete at her maximum capacity. Others are thankful for pacing of 55 beats per minute minimum and around 170 to 180, but she wants more of a runner's experience and wants to know. She has a Boston Scientific pacemaker, and had a treadmill test to determine her issues, but passed it with no issues. She has dual leads, 40% paced atrial and 100% ventricular, and just wondering, is there somebody or some way she can learn how to train and have her pacemaker settings adjust into that?
I would say that the best strategy would be to work with the individual physician that is managing this device. There are so if this person paces in the ventricle 100% of the time, that means they must have some complete heart block, or at least an indication for pacing the ventricle. And that will restrict the upper rate to which because there's only so much time. And that time is eaten up from the top chamber to the bottom chamber, and then from the bottom chamber to the top chambers. So if somebody has complete heart block, and if somebody needs to set, there's lots of different parameters you have to set to make sure that it works properly. So I don't think that I've ever seen a patient with a pacemaker program at 170 beats per minute. That's just virtually, like, not sure it can be done, actually.
I think she's talking about the upper limit for exercise.
Yeah, but that's what I mean. Like, I don't think that the pacemaker will track up to that high rate. Usually the tracking ends about 120, 130. In a young person who's very active, maybe 140 or 150. That's max that I've ever encountered. So basically what I would say is that, there are two ways. So if this person has a Boston Scientific device, there are two mechanisms which have to be enabled. One of them could be enabled or both in these devices that will actually increase the heart rate with activity. One is a piezoelectric crystal. So basically, motion produces distortion of a little membrane, and that is translated into increased heart rate. And then Boston devices also have minute ventilation. So actually, there's a signal that's sent between the leads and the device that figures out how deep somebody is breathing and how frequently they're breathing. And so those instruments help determine for a Boston Scientific device whether to increase the heart rate and how much. You can make the device more sensitive so that it reacts sooner, ramps up sooner, and then maintains the level at a high level for longer. Or you can make it less so. And so typically when patients need this optimized, we have them come, we walk them, we do the walk through the clinic or taking stairs, and then reprogram it if it's inadequate, and then reprogram it again, and then they go home. And then they tell us whether that was better or worse. So it's really very individualized, and also clearly this person received a pacemaker for a reason. So there may have been some interval event that actually is making things not quite as possible as they were before. So that could be a consideration. So there are a lot of issues with programming and the timing of things. Like we actually are bound by limits in time for the different things.
Absolutely.
So between that and the fact that some interval health event may have occurred that's actually making things harder.
Yeah, that's not very straightforward. And also, not all, but some clinics will let you get on a treadmill. So maybe she could do that. But
I think she said she did that.
Oh, yeah, you're right.
And it was fine, which tells me if she said that it was fine, that suggests that the heart rate did increase appropriately.
Yeah.
Now, treadmills are usually done, over a period of 18 minutes or so at most. So there may be a difference, when somebody's trying to exercise for hours.
Right.
But what I would say is that in a device like this, making sure you take deep breaths, increase the breaths as necessarily, and, kind of wiggle your body, right? And especially this is an issue for bikers who don't have a Boston device. You could be stationary and not really move your chest at all, and you're not going to get quite as much of a heart rate increase unless you actually wobble a bit.
Yeah, I found that because I have the type of device that does not sense the oxygen.
Yeah, it's rare. Many companies had it and they actually did not find benefit to it and phased them out.
Wow.
Boston is the only one that actually is keeping it. So, it's intellectually very appealing. There are really no studies that compare one device to another. A company will always say, like, we have a feature that other companies don't have, and it should be better. But who's going to pay for research that shows that one of those companies' devices are inferior?
Yeah,
it would have to be NIH.
Yeah.
And they're not going to do that because it's not an important question enough for them.
Yeah, I agree. Are there sports medicine cardiologists that could possibly?
There definitely are. Usually, there are certain conditions that put people at risk when they're exercising strenuously. And so, usually I would say especially at academic centers, there really should be a person who is interested in sports medicine. That person generally would be an electrophysiologist, but it doesn't have to be. So there may be some interdisciplinary collaboration that would be required to help with this issue.
Yeah, and I know in my area, I actually looked for that. I'm not an athlete, but just to get my settings more for activity, and I couldn't find anybody in my area. But I think if you look probably in large cities, right, at academic medical centers, maybe, possibly, you think they might have that type of sports.
Well, and, I also would say that, sometimes this should be an iterative process. That you actually, you go with a complaint and some intervention is made and then you go home. You shouldn't assume that they cannot help you. You should go back and say, hey, I'm still having this trouble. Try harder. And so there's lots of tricks up the sleeve that somebody can, if you advocate for your health and you tell your healthcare provider that, hey, this is still not working, they have other things that they can do. So I would just caution people against dismissing it. Oh, they couldn't help me last time, so I'm just going to give up and not seek, additional help because, there are certainly patients who come with a complaint of not getting their heart rate high enough, and we turn that feature on, and then they say it feels like their heart rate is racing all the time. And so then they have to come back and we have to tune it down.
Yeah.
And so I would advise just patience
Yeah. Don't just
and working through the issues and trying to figure out what activity really causes the problem. Now there are these smart watches that can actually help also the person determine what the heart rate they have. The more correlation you provide to the physician with the heart rate and what you were doing and what you were feeling, the better care you're going to get.
Yeah, I agree. To participate in your care, particularly if you want something special like sports adjustments to participate as much as you can in helping your clinic to do that for you. Okay, next question. So this is back to what you were talking about, the ICD therapy. So how to prevent ICD therapy. And here is his situation. So he has VTAC and an ICD in his chest, in spite of many adjustments, he says, by different electrophysiologists, when he calls it going off the deep end. When he goes off the deep end, his device frequently hits him 7 to 8 times in a row. Frequently, he loses consciousness. He said he has PTSD from this and is frightened to death about getting therapy. He never knows how long it will continue. So what he wants to know is he's trying a lot of different options. He wants to try to do something before the therapy goes off. So he's tried putting cold water in his face, holding his breath, bearing down like he's having a BM, pushing and constricting his breath similar to isometric exercises, squeezing his nostrils closed with his fingers and blowing hard against the closure. What else can he do? He wants to try to not get shocked all the time.
Yeah, so when patients receive a shock, the first thing that we determine is whether the shock was appropriate or inappropriate. Appropriate shock is one that is delivered in response to a life-threatening rhythm. An inappropriate shock is one that gets delivered not to a life-threatening rhythm, but a rhythm that's fast nonetheless. The major discriminator in ICD therapy is the heart rate. And then what flows from that, there are other discriminators that can be turned on or off depending on the device manufacturer and depending on the condition of the patient and what is known about their health. So what I would say is that it's hard for me to know for sure whether these shocks are appropriate or inappropriate. If they're appropriate, that suggests that somebody needed to be shocked 7 times, right?
Right.
So meaning their rhythm actually restarted. So it terminated the life-threatening rhythm and then it restarted.
Yeah, maybe it saved his life at that moment.
Correct. Now, it's entirely possible that that this person has a relatively slow ventricular tachycardia, and it is not too far from a normal heart rate that the patient would normally get, and that discriminators for some reason are not making the cut. They're not able to tell whether it's a life-threatening rhythm or not. And one would have to look at the specifics of that and exactly understand what the rhythm is when the patient receives a shock and how the so-called discriminators can be adjusted to prevent it from happening. If the defibrillator is programmed at a very low rate for shocks because of known slow ventricular tachycardia, it may be very difficult to prevent inappropriate shocks. And of course, when you receive a shock, you're going to get upset. And so your heart rate is going to go up. And so it could be, like a catch-22 situation. If it is an appropriate shock, oftentimes people will receive several shocks because their heart rate remains elevated.
Yeah, it kind of gets stuck in a loop a little bit, it sounds like.
But what I would say is, certainly if from the maneuvers that the person described, they would be expected to terminate a supraventricular rhythm, which is unusual, so it's not the ordinary thing. So I wouldn't necessarily advise that person to do those things unless it was known that the patient has a supraventricular rhythm that's causing these inappropriate shocks. And clearly for that reason, there are medications and there are procedures called ablations that can be done to reduce the chance of that happening.
Okay, so are you saying it's not a good idea for him to do these things he's trying, throw in the cold water?
I'm saying that I don't think they'll work unless it's one of those rare circumstances in which this condition applies. So I would say there's no downside from doing it, but I wouldn't advocate it as an effective way of dealing with this issue unless it's this one narrow aspect of elevated heart rate that it is. We just don't know enough about the intricacies of the situation to definitively answer that.
So maybe he could ask his electrophysiologist about, the reasons he's getting shocked, maybe get a little bit more educated to understand, and then, by his electrophysiologist to see why he's getting the shocks and if there's anything else. He does say he's asked and they've made a lot of adjustments.
Yeah, and so I don't know. It's hard to know what and of course we don't know if it's transvenous device or a totally subcutaneous device.
And I don't think there's a
know,
pacemaker involved. It doesn't sound like.
right. So if it is a totally subcutaneous device, when patients exercise, their EKG may change just enough for one heartbeat to be counted twice sometimes. So sometimes if patients have totally subcutaneous device, we do put them on a treadmill just for the purpose of observing how the shape of that EKG signal changes at higher heart rates and whether that is going to trigger an inappropriate shock.
Okay. So he needs to go back to his clinic basically and try to get more.
I would say they should be able to explain what the problem is. And if they can't explain what the problem is, then maybe getting a second opinion would be reasonable.
Yeah, I would say the same. Yeah, always. And even if sometimes somebody's going to a very good doctor, but for some reason they just don't mesh, if it's better for you to get another doctor, then just get another opinion. You don't have to switch right away. You can always get another.
Correct. And what I would say is that generally speaking, as physicians, we have our vocabulary that we use and patients have their vocabulary that they use. And sometimes we say things that don't make sense to patients. And so maybe we understand what's going on, but we're not able to convey it. And so I think we all can do better at communicating. It's very important, to be able to be at the level and explanation. And sometimes we just fall victims to our own success. We know so much that we're going to use these medical terms and then nobody's going to understand us.
Yeah. And sometimes, and I found this even in my own recent experience, sometimes the electrophysiologist has a nurse you can talk to who can explain things, and sometimes they don't. Sometimes their nurses or medical assistants aren't real up on everything, and occasionally they really are. My experience is that the device clinic people typically can explain things. I've rarely had a time they couldn't. It's usually the device clinic that knows how to explain these type of questions that I would ask.
Yeah, I would say experience matters. Sometimes when we hire a new nurse, they have a period of 6 months during which they'll learn or not.
Mhm.
And then, it could be somebody that's a year out, or it could be somebody with 15 years of experience. They may be able to help better.
Yeah.
So it's hard to know. But I would say I would keep trying.
Yeah, definitely keep trying
to get to the bottom of this, because it is, when people receive a shock, whether it's appropriate or inappropriate, it is very troublesome to everybody. Patients will not behave the same way. They're always afraid of doing certain things. And so while we try to make people active, we encourage activity, they may actually slow down after receiving a shock in fear of getting another shock.
Yeah, absolutely.
People reflect on their mortality. People may develop depression. So this, reducing shocks has been at the forefront of the ICD therapy field for many years, and improvements have been made with programming settings in technology development that reduce the inappropriate shock rate to as low as possible, but sometimes it happens nonetheless.
Yeah, absolutely. And it is scary. And also I would ask about what is the next step in the plan, because if he's getting shocked that much, he must be having lots of rhythm issues,
Well, again, that's what we don't know, if it's appropriate or inappropriate.
No, and if he's getting VTAC all the time, are they planning an ablation? Kind of what's the next step? Are they doing something else? I mean, just ask.
Or medication, right.
Or medication. Right. I would ask for sure the electrophysiologist. Like you said, I'm sure they have a plan, but they may or may not have voiced it.
Yep.
Yeah. Okay, the next question is about intimacy. So one partner having a pacemaker and one partner having an ICD, is it safe if they get close to each other? And she said, will anything bad happen? Will it explode? Will anything bad happen?
It should not explode. Let's just first maybe talk about a person who has a defibrillator and has a partner. Sometimes patients may receive inappropriate shock during sex, which can be startling, but should not really affect negatively the other person, meaning the other person is not going to get that shock conducted to them. Skin is a very good insulation. So I would say in a dry environment, it shouldn't really matter. Now, outside of a discharge of the ICD, there actually is absolutely no interaction between the two devices.
So totally safe.
So it's totally safe.
Okay. So the only thing to know is if somebody has a ICD discharge, it won't affect the partner, but it's certainly going to affect them.
Correct. And it's very uncomfortable, right? I mean, it's going to be unpleasant and worrying and all that stuff. But in terms of immediate health consequences, there are really none.
And this would just apply to being close in general. Doesn't have to
Correct.
be intimate.
Correct.
It's closeness. Okay. So the next question is about heart damage from a pacemaker. So this person is from the UK and feels her area is not up to date with things. She's 60 years old, has suffered chest pain since getting her pacemaker 6 months ago, and it's getting worse. She's been informed by the cardiac team that on a rare occasion, pacemakers can damage the heart. Is this true? And would you please explain?
Well, so it sounds to me like there's really two questions. One is this person is having chest pain following pacemaker implantation. And so that should be evaluated, even if the patient does not have a pacemaker. We don't have many details about the types of the chest pain and how it feels and all that. The separate issue is whether the pacemaker can damage the heart. And, anytime that you put anything into the human body, we can, in theory, damage things, right? And so there are certainly screws in pacemaker leads that way, in ordinary places where pacemaker leads are placed, they don't damage anything unless they erode from one chamber to another. But then that usually presents as a collapse, like much more significant presentation, more dramatic presentation than this. Now, chronic pacing of the ventricle may cause heart failure. It doesn't happen very often, maybe in 10 or 15% of patients after many years of pacing a lot in the ventricle. And there are ways to approach that, but I don't think that's what this person is asking for. From the question, it sounds like the chest pain should be evaluated on its merit. Patients certainly can get what's known as pericarditis following a pacemaker implantation. It's not common, but it can occur, and it's usually investigated by, looking at EKG patterns and doing an ultrasound of the heart, seeing whether there's fluid outside. You can do a CT of the heart to see whether the lead has migrated through the relatively thin right ventricular wall and into the outer space around it. So if chest pain is related to the pacemaker implantation, then that aspect of it should be evaluated.
Yeah, that makes sense. So,
or it could be truly unrelated. It's just a coincidence. And that should be evaluated on its own merit.
Exactly. And I mean, there's obviously some purposeful damage like you have to do when you put the pacemaker and the leads in. That's still
but that's that's
really damage, but
it's of no clinical significance. So basically what you would say is, okay, if you took that tissue out many years later, would you see scarring with a lead embedded into the heart muscle? And at the very beginning, when pacemakers were being manufactured many decades ago, there actually would be some of a damage of this kind. And that's why thresholds had to be adjusted 2 months later when they finally reach a plateau. But for many, many decades now, the lead tips actually have a steroid in them to reduce the type of inflammatory reaction of the heart.
It's good to know.
And so we ordinarily do not see any changes in the lead parameters after they're implanted in the heart. So I would say that is more of a theoretical consideration and not really clinically important.
Yeah, not clinically important or significant. So maybe there could be damage and it does need to be evaluated as to why, whether there's anything of high concern or not. Okay, the next question has to do, and I think you've answered a lot of this, so if there's just I'll read it, but if there's anything else you want to add. Activities with a pacemaker and ICD for all people. He's getting mixed messages from his EPs, support groups, and ICD manufacturers about activity restriction. There's a lack of specific information for those that are very physically active, either in sports or in a workplace. He wants recommendations to discussing details with the EP is not realistic, giving the time, basically an appointment, right? There's really not enough time. The EP doesn't have the time to deal with all these things. Even when discussed, the doctors are reluctant to give definitive answers. So here are his questions. Are all repetitive arm movements above the head to be restricted?
The answer is no. And again, I'm talking past the 2-month period,
past
right?
the 2 month, correct. Yeah. I don't restrict any of mine at all. And what weight training movements are suggested or not allowed? And I think you already covered that. Just if you're an Olympic athlete, check with your doctor, basically.
That's right.
But otherwise, likely safe.
Yes.
Are arm movements where impact occurs, like chopping wood, not allowed?
Many of our patients chop wood and it's not a problem.
Yeah, with you there. What if the ICD is struck by a racquetball, baseball, basketball, etc.?
Occasionally patients may be hit either with a ball or, by their grandchild or something. There are certainly times when people have pain that persists for a number of days because the device is close to the skin. And so if the impact is pretty strong, I guess it has the potential of bruising it both inside
Yeah.
and outside. From the point of view of device functionality, it would be incredibly unlikely that there would be a problem with just ordinary play. If you receive, a hit in that area, if you have home monitoring, you should be able to call the doctor and say, is everything okay with my device?
Yeah, they could send a transmission, right? From if
Correct.
they
They
have,
can send a transmission and they can really tell you whether the device function is affected in any way. It shouldn't be, but again, I guess it all depends on the specific circumstances
yeah, and
involved.
I have done that myself when I traveled the one time and I was concerned that I was close to electromagnetic field. I sent a transmission. People can send those from their home monitor or from their app on their phone. But anyway, I sent a transmission and they checked it to say it was fine. Yeah, I agree.
Yes.
Okay, the next question is about participating in activities that are held miles and miles away from immediate transportation. So I guess just for safety issues, if they're doing an activity that's out in the middle of nowhere, up in the mountain.
I think that would be best answered by the physician that knows the specifics of the history of this patient. Just the sheer presence of a defibrillator or pacemaker should not be a reason to deny oneself an otherwise important activity in a person's life. But I acknowledge that we don't know what the recent heart rhythm issues have been and other issues. So I'm not sure that I could say that it's absolutely safe to do that for each individual patient. For most patients, it would be reasonably safe.
Yeah, it's also a risk for any of us, whether we have a pacemaker or not, because if you get injured,
Correct. I mean, there's no doubt that,
might be no cell service.
your access to a hospital is best when you're just right outside a hospital.
Right.
And any distance you're away, it's harder. I would say certainly after a recent implantation, I would advise that somebody waits a period of time, when they all heal. And I would really rely on, what was the indication for the device implantation? Were there any interval events that, was the therapy being actually used by an ICD? That would make a big difference. And so you kind of have to look at the whole trend of what's going on.
Yeah.
But, most patients with, let's say, defibrillators, the events are extremely rare. And so, a risk of 1 or 2 days being away, something bad happening to a patient.
Yeah. Probably not that much more than the average person. Something could happen. Okay, so last question. So this one is similar to another one. This is for settings for athletes and active people. So he's found it very difficult to get more detailed information from manufacturers or doctors about optimizing device settings for high activity. His EP told him not to worry about those device settings. But from various support group discussions, these have been very important to athletes for quality of life. So he says he feels like the level of support seems to wildly vary between cardiac clinics, which I would say I agree from my own experience. And from the Pacemaker Club, I've read a lot of posts also from people. So what the question is he wants to know, where are the best hospitals, clinics, organizations, resources for getting help with pacemaker settings for active people or athletes? And there were dozens of questions on the Pacemaker Club about this.
In general, a larger organization, a large health system, or a university should have more resources. And in a large system, there may be people who have an interest in working with a group of patients with a specific issue. I don't think that I could make any specific recommendations about which specific facility to go to. I guess I would advocate persistence, and basically demanding that this issue gets explained properly. But there may be times when this optimization may not be fully possible to the satisfaction of the patient. So I don't know
Makes sense.
really what the limitations are there. I do know that there are these issues with rates, right? There are certain reasons why in some patients, you cannot program a device to go faster than a certain rate because of the interlocking interactions between parameters.
That makes sense. Yeah, my experience also as a patient has been that um, some clinics are a lot more willing to be a lot more engaged. Some physicians are a lot willing to be a lot more engaged. Some physicians don't necessarily want to make a lot of changes, and some are very open to making changes until you're 100% happy. I've
Correct.
I've switched doctors and clinics several times to get to one that actually met my satisfaction, right? And I did have to go out of my state to a academic medical center to get a clinic that had very, very experienced device techs. I mean, they were really great. They seemed to know everything, which has not been my experience elsewhere, but I travel very
Right.
for that.
But I do want to make sure that I am certain that there are lots of, small practices that have excellent people working
Oh,
in them. It's just you don't know who they are
yeah,
necessarily. But
yeah,
I would say, yeah, I just don't want to create a scenario in which we treat the more of a primary access places as being inferior. And so if that connection is not right for that person, they should find a practitioner that is meeting their needs,
yes, yes,
which are both medical and psychological,
and
right?
psychological.
And connecting and making sure that you have some shared experiences where you say like, yeah, I trust this person.
Yeah,
A lot of times in medicine, if the patient doesn't trust you, they're not going to do what you're asking them to do, number one. And so building trust between the physician or the device nurse and the patient is very important. And it's not all just, quote unquote interrogation. It all depends on personal engagement of each individual.
yeah, no, I totally agree with you. And I want you to know, I wasn't dismissing the small clinics because I actually went to a
Yes.
very small local clinic and the electrophysiologist was amazing. But I have a complex problem and it was not something he felt that was in his wheelhouse to manage. I mean, he was great with setting the pacing and he did it himself and he was very good. I I did have that experience also. So that was our last question. Thank you, Dr. Crawford. You've been extremely great and helpful explaining your presentation and answering the questions. We have some resources here for people on the slide here, Four Hearts Pacemaker Club. And we want to thank you very much for joining us. And we'll see you on the next presentation.
Thank you. My pleasure.